Hey, welcome to the Go-To Physio Podcast. My name is Dave O'Sullivan, and in this podcast, my aim is to give you 15 years of my experience in professional sport and private practice and share that knowledge so that you can get real-world results with your complex patients who have failed traditional approaches. I hope you enjoy the show. Hey, welcome to the Go-To Physio episode number 49. And my name is Dave O'Sullivan. Absolute honor, privilege to have you here for another episode. Now, we're on season 3, episode 15 of this current package of episodes. And in this current package of season 3, we're talking a lot more in depth around my book, my Amazon #1 best-selling book, Happy Progressing Patients. Now, we're going to talk about hands-on treatment today, which is chapter 11 of the book. So if you want to pick up a copy of the book, you don't need the book for this episode. But if you did want the book to go into more detail, you can get it at the gotophysio.com/book. Now, in this chapter 11, we've gone through obviously making sense of the symptoms. We've designed a treatment plan with the patient. Now we're going to start to look at how do we apply our hands-on treatment. Now there's some key principles that I use with hands-on techniques. And in page 179, 180, I kind of allude to that. When I first started out with hands-on techniques, you know, I used a lot of kind of pin and stretch and massage and soft tissue mobilization. I don't use a whole lot of manipulations, mobilizations, if I'm being completely honest. So I think manual therapy, you know, it's got a bit of a love-hate relationship. Some therapists love it, some hate it, some are for it, some are against it. Now, of course, you're going to have your extremists who, you know, say, you know, you should absolutely under no circumstances be touching patients with your hands-on techniques. It's creating patients to rely on it, and it's doing all these harmful things. Okay, and yeah, there will be a small percentage of patients that certainly rely on hands-on treatment, and I'll show you how to overcome that today. Then you've got the other side of the coin, where therapists probably, you know, they're telling people they're breaking up scar tissue and they're doing all this and this, which in my complete honesty, I thought that's what I was doing when I first started out as well. Okay, so, you know, and those people might instill fair dependence on hands-on techniques. So how do we overcome that dependency on hands-on techniques, use it responsibly, and then ultimately as part of a graded exposure plan? And that's what we're talking about in chapter 11 of the Go-To Therapist method. And that's really chapter 11 of Happy Progressing Patients, which outlines the Go-To Therapist method. Now, the big key thing that we have to understand is that hands-on techniques are tactics, okay? They're techniques, okay? Now, the beauty of our profession is we can use a number of techniques. Now, when COVID hit and I was treating patients with telehealth, I was using obviously no hands-on techniques, and we're still able to get results. The reason we're able to do that and have the confidence to do that is because we've got a system, a strategy that ultimately the tactics feed into. So one of the key things that we need to understand is that if you are just using your hands, hands-on techniques, you're going straight to your favorite, you know, mobilization, hands-on technique, soft tissue release technique, whatever it is, without thinking, then you're just on a tactical level. In order to get long-lasting results and deliver value-based treatment plans, we need to be working on a strategic level and with principles, okay? So my hands-on techniques fit within the system, okay? And that's where we understand where the patient is, where they want to get to, what's the obstacle standing in the way. Now we can decide on the tactic. And sometimes for me, hands-on techniques will be a lot faster way to get a patient to the next level of graded exposure, okay? It will complement the treatment plan. There'll be times where I think, you know what, there's absolutely no way that this patient's nervous system is letting go with hands-on techniques. So an example of that, an applied example of that might be if I was helping the iliocostalis to decrease its tone, to decrease the tone and improve the movement of the rib cage, for example. You might find some patients, they've got a lot of guarding, okay, through those tissues. And then in that scenario, go, well, you know what, my hands aren't going to overpower their nervous system. So that's where I might use an isometric, or I might use some type of movement to help facilitate some load through those tissues, which then naturally tends to decrease the tone. Then I might use my hands-on techniques. So you can see there that we've got a strategy. I know that I want that iliocostalis to let go of some of that protective tone to allow the patient to relax their back. Now I've got strategies to do that. I don't have to be attached to just one technique. So I think if you can move away from a tactical level, have a structured step-by-step system that allows you to have a strategy with your patient of where they are, where they want to get to, what's the obstacle, then we can pick and choose our tactics. Okay, so whether it's dry needling, whether it's hands-on techniques, whether it's scraping, whether it's rehab, whatever the tactics that you're using, okay, then we know where they fit along the graded exposure. Now, the other thing I want to talk about as well is you will never, ever be able to outperform graded exposure with your hands, okay? So from 15 years working in pro sport now, the biggest issues that you're going to come up against is usually when the pain's starting to ease and the patient's going back into the real world, okay, or whether they're going back. So for an athlete, it's going back into training, okay? There's no amount of hands-on techniques can compete with graded exposure, low tolerance to tissues, because that's what they're going to need at that level to bridge the gap from low to high level rehab so they can move with thoughtless, fearless movement. Now, sure, you might be able to change pain in the first few sessions and increase range of motion, all of that. But what happens when the patient goes back into the real world? Okay, are those changes sustainable? And very often, if you find that your patient's pain's coming back again, or the range of motion is constantly tightening up again or reducing again, then the chances are we haven't bridged the gap from low to high level rehab. Okay, we haven't shown the nervous system that it's safe to keep that range. Okay, and that's where we're going to need exercise and rehab in order to reassure the nervous system. So for me, you can't, certainly you could have one without the other, in terms of you could rehab a patient without touching them and doing hands-on techniques. Of course you can. And if you work on a strategic level, then that gets even easier, okay? If you said to me tomorrow that you cannot touch manual therapy is banned, you cannot touch a patient again, do any type of hands-on techniques again with the patient, you can just use rehab. Could I make changes? Would my confidence be knocked? Absolutely not, because I've got the strategy in place and then it just becomes tactics. Would it be as quick? Probably not, okay? If you said to me that you couldn't use rehab anymore, you can only use hands-on techniques, then that's going to stress me a little bit more, okay? Because I know realistically, to bridge the gap, I'm going to have to put them in positions, update the nervous system, show it that it's safe to tolerate load, because that's very often what the issue is, that the nervous system can't tolerate the load on the tissues due to maybe false beliefs around that there's still a perceived threat there. Okay. Now, the good news is when we work on a nervous system level, we can change things very quickly. And that's the real big thing, is when we understand the strategy and we have a movement model, we've got a pain model that we understand. We understand models have limitations, of course they do, otherwise there wouldn't be models. Then we can understand that actually the hands-on techniques fits at a certain criteria. So for me, hands-on techniques is actually useful to increase load tolerance, but it's increasing load tolerance through a certain graded exposure level, okay, which is pretty much on the floor, okay? So it's not going to be exposing the tissues to a whole lot of load tolerance, but it's going to expose them to some, okay? Then we put them in positions where we can increase that load tolerance with rehab exercises and movements, okay, where again we use strategy to put these tissues in positions where they have no choice but to tolerate load. So the big thing that I want to take away from this point is that if we're working on a nervous system level with hands-on techniques, that you're probably going to change the range of motion and you're going to see the change in probably a minute or two. It's not going to take you 15, 20 minutes and then the nervous system is going to change, okay? Or certainly if it does change, it's probably the fact that the patient has just been sat there and relaxed, okay, for 15 minutes, okay? And you've helped them get out of fight or flight, in my opinion, okay? So the hands-on techniques, if the changes are going to change, they're going to change fast. So that's really good news for us, because it's going to save your hands, your thumbs, dig it in for 5-6 minutes, okay? So that's going to be one of the big things on a high level. We're working at a nervous system level, which is good news, because if things are going to change, they're going to change fast, okay? Now, the key thing that we want to do with our hands-on techniques, or certainly that I encourage therapists to do, is that we never want to treat what I would call blind, okay? So the hands-on techniques, it's a tactical level, but what we also want to do is we want to think twice, treat once. So you want to use your hands-on treatment techniques like a sniper rifle rather than a bazooka. So what I mean by that is go in and just go, okay, back pain patient, you're going to get the QL technique, you're going to get the glute technique, you're going to get the psoas technique, the hip flexor technique, whatever technique you want, okay? I think that's dangerous, okay? So that goes back to then you're just working tactically. If we work strategically, then we've identified this is where they are, this is where they want to get to, this is the obstacle. So we think twice, treat once, okay? So rather than just smashing everything, okay, we're thinking about clinically reasoning, answering our critical thinking questions, and then using the hands-on techniques to influence those tissues, okay? And then very often when we recheck our key performance indicators, you're going to find much more long-lasting changes. So the pain's not going to keep coming back after 2-3 sessions. All of a sudden, then that novel experience of hands-on isn't so novel, and what you were doing previously isn't actually influencing change. So that's the first big thing that I talk about in page 184, think twice, treat once. Okay, soft tissue techniques are simply tactics to help you get from point A to point B within the graded exposure. And then in page 186, I say use KPIs to mitigate risk and give you unshakable confidence. Okay, so what I mean by that is we use this whole process of test, treat, intervene, retest. Okay, so what I mean by that is if we have a key performance indicator like a toe touch, a backward bend, some kind of range of motion test, whatever it is, then when we intervene with our hands on with one particular tissue, then we want to retest. Okay, so that's really useful for me then, because if we can make a change with that and we know exactly the peripheral tissues that we've influenced, and of course there's other things besides just the tissue that's changing there, central nervous system, etc. But now what I'm going to do is I know the nervous system likes that, okay? So, or certainly found it useful. So what I'll do then is I'll put those tissues in positions with my rehab to then further load those tissues, okay? So that gives me confidence then that I am on the right track. If I do hands-on techniques and it doesn't change the range or doesn't change the pain, then am I going to design my rehab exercises focusing on those tissues? Probably not. Okay, does that happen sometimes? Of course it does. Okay, so sometimes I do a hands-on technique and it doesn't change anything. But that goes back to your strategic level. The better the strategy, then you're going to think twice, you're going to treat once. Okay, and that happens less and less the more I think. Okay, so your key performance indicators are very good. And for me, what I teach in the mentorship is never ever treat something without having a key performance indicator to retest. Okay, and then that gives you a lot of clarity around the actual graded exposure and the where you're going next. Now, the last thing that I want to talk about here is page 187, where we decrease co-contraction centrally by improving co-contractions peripherally. Okay, so an example of that again is think twice, treat once. Okay, so for example, a back pain patient, and I talk about that in the book, might go down to touch their toes, and they might have a couple of issues. So we say, okay, iliocostalis isn't letting go. It's a lot of protective tone. So we want to decrease the protective tone, allow that tissue to lengthen a little bit easier without guarding. And then we also know that their hamstring maybe isn't taking enough load as well from an assessment that we've done on the bed. Okay, so where do I start there? So again, with that patient, if I go to recheck their toe touch and their key performance indicator, if I just treat their low back, is that stability component or that low tolerance through the hamstring going to be solved? Absolutely not. So is the low back just a second order consequence where it's getting quite rigid and protective due to somewhere else in the body not tolerating its load? Okay, so now when I start with my hands-on techniques, I could start improving low tolerance through the hamstrings with my hands-on and my rehab, and then that very often is going to relax the iliocostalis anyway as a second order consequence. So we talk a lot about that second order consequences in the Go-To Physio podcast also, and it's actually episode 38, the powerful concept of second order thinking. So that'll be an example of second order thinking there. So very often if we improve low tolerance peripherally, we'll actually decrease all these rigidity type behaviors from my experience with patients. And then the last thing I want to talk about this week is page 189. You'll see that very often the hands-on techniques. So in the first session or two, we might be doing a bit of hands-on techniques on the symptomatic area. And then as we progress through the sessions, we're going to be doing less and less hands-on treatment and more rehab. Okay. So again, from my point of view, I'll use my hands-on techniques. Probably the most I'll use them is in the first 2 to 3 sessions. But by then, I know that really, if I keep doing the same thing again and again, the novel experience is going to waste away anyway. But number 2 is very often I need to expose those tissues to graded exposure up the low tolerance chain. So in the first few sessions, I'll be doing some hands-on techniques. But as I go session by session and into the last few sessions, I'm actually doing very little hands-on techniques at that point. Okay. And if anything, I might be doing previous injuries and looking at other parts of the body at that point just to help the tissues be successful. So if you find that at session 3, 4, 5, or 6, you're still doing the same amount of hands-on techniques that you were doing in session 1 with the patient, then I would respectfully get you to look at your graded exposure ladder. Okay. And are we generally progressing up the graded exposure ladder? Because if they're losing the range of motion, if they're not keeping the pain experience away, or whatever progress you were doing and it keeps coming back, then are we on either the right tissues, the root problem, okay, or is it a graded exposure issue? Okay, so that's just something to think about as well. Okay, so that's it for this week. Okay, the big thing I want you to take away here is hands-on techniques. A lot of good with them if we use them as part of a strategic model rather than just a tactical level. If we're at a tactical level, we're not thinking, we're just using our hands-on techniques, and we want to control the narrative. Maybe we're saying, you're breaking up scar tissue and all that. That's probably not good. If you want your patient to not become reliant on your hands-on techniques, then make sure that the rehab exercises you're using, they can feel a difference. The best way to do that, they can feel a difference throughout the day at home. Okay, your rehab should be helping your patient solve a problem in the real world. It shouldn't be about just strengthening a muscle in isolation. Okay, because there's a nervous system above all of that controlling it. Okay, so we want the hands-on techniques to help us as part of the strategy, but we don't have to rely on hands-on techniques if we don't want to. Okay, so you can use them, control the narrative. Okay, be careful what you're saying to patients. Okay, about scar tissue and all of that. It's probably just a nervous system change. Okay, from my experience. And then, as I said, if we use it with everything else, if it's going to change, it's going to change in 1 to 2 minutes. From my experience, probably less than a minute. Okay, check your KPIs and then continue to load out those tissues up the graded exposure ladder if the nervous system likes the changes that you are getting. Okay, so that's my advice for hands-on. Is it 100%? Probably not. Okay, do I know everything? Absolutely not. Is there things that I'm doing at the moment that I'm probably going to change what I'm saying in 5-10 years as maybe more research comes out? Probably. Okay, but I think it's very important that we're comfortable that actually we don't know everything and that I'm not attached emotionally to one side or the other. Okay, we've got that equanimity. Okay, if you want that, we can just stay there. We can look at either side and go, okay, the truth's probably going to lie in the middle here. I'm not emotionally attached to what I'm saying here. Okay, it is what it is. And if research comes out and it shows actually the reason I'm getting these results is because of this, then fair enough. I have a responsibility to update my belief system and communicate that to patients. Okay, so I hope that helps. If you want any more information in the Go-To Therapist method, how we use hands-on techniques in the method, or how we use the full system, if you want to get off that rat race of being on a tactical level with hands-on techniques, you want to get a step-by-step strategic plan for your patients, then head over to thegotofysio.com/mentorship. We've got all the details there for you, where you can schedule a call with either myself, Shane, my head physio, or one of my team. All right, that's it for this week. Have a great week, changing lives of patients, making massive, long-lasting impacts on your patients' lives. Have a great week, and I'll see you next time.